I'm Dr. Rovinsky. I'm from University of Hawaii. I've been doing the direct anterior approach for 10 years, and I think that the major advantages of this approach are restoring leg length and offset with precision. And I've been using the HipGrid to help me with that, and I find that it gives me very precise information from which I can make decisions. So I'm going to present a case here of a young man who's been through an awful lot. He had bilateral hip avascular necrosis. On the right side, he had stem cell therapy and a hip arthroscopy, and on the left side, he had a blade plate. And I'm going to talk about how we use the HipGrid to restore normal hip anatomy, leg length, and offset, particularly in a case where you have distorted anatomy and you're matching components from different systems. So we elected to do the right total hip replacement first because that was less complicated. He did not have a lot of hardware in place, and he did very well with the right hip and loved it and was anxious to return for the left hip surgery. The left hip surgery is complicated because he had increased leg length and increased valgus from the blade plate, and also the blade plate extended with 4 screw holes, so we had to use a different stem to bypass the screw holes and avoid the risk of femoral fracture. So we set up with the HipGrid, and after making our femoral neck cut and removing the blade plate, we want to center the grid on a flat pelvis. So we make sure the obturator foramina are even and symmetric. We make sure a line down the center of the sacrum hits the symphysis pubis, and we make sure the grid is aligned in such a way that the lower line is across the teardrops. This gives us a very stable starting point. We center the C-arm on the acetabulum, and then we can ream our acetabular component after appropriately medializing with a goal inclination of 40 degrees. And the lines on the grid are 35 degrees and 40 degrees, and if you split the uprights, you have the inclination correct. I look at my anteversion clinically. I can see it with my exposure, and I can feel the rim of the cup and the anterior rim of the acetabulum. That's my primary information for deciding anteversion. But it also helps to check with the C-arm, and if you see about 1/3 of an ellipse, then you have an appropriate anteversion of 20 degrees. Now, after broaching the femur, I can check and make sure that I have good fit and fill, and also make sure that my femoral broach and my planned femoral stem goes well past the screw holes that are in the femur from the blade plate. Once we're happy with the stem size, I can now check my leg lengths. And in this case, we can see that our leg lengths are short. And one advantage of the HipGrid is I can see exactly how short I am. And in this case, I'm 1.5 boxes short. So I can make that up with an alternate head choice. So by increasing my head size and length, I can match my leg lengths and also make sure my offset is restored. This is a picture of the final implant and a final AP pelvis. So the HipGrid allowed us not only to restore offset and leg lengths, but to do it in less steps and taking less fluoroscopy images, because intraoperatively, when I saw that I was short, I knew exactly how much I had to add back to even up my goal of matching the other side. This is his postoperative film and a postoperative cross-table AP and lateral pelvis.